From the Toronto Star, I'm Adrian Cheung, and this matters. There's a lot of talk right now about how and when we can reopen our society. Ontario Premier Doug Ford says plans are in the works, but not everything will restart all at once.
We're going to open it up with a trickle and just let it flow from there and constantly measure. By no means are we going to have, for instance, the May 24th weekend, we're just going to open things up. That is absolutely not going to happen.
So when we do reopen, what goes first? Increasingly, doctors and the Canadian Medical Association says it's the healthcare system that should be at the top of the list. Now, technically, healthcare is open, but not to every patient or case up to this point. That's because hospitals have been bracing for a surge of COVID-19 cases. But some emergency healthcare workers say any non-COVID-19 cases they're seeing are very serious. Doctors often aren't seeing these patients until it's absolutely dire. On top of that, they say many of our hospitals have the capacity now to treat our regular health problems. Today, we're heading back to the front line to talk to an emergency room doctor who's been on this podcast before. We're taking a look at what ERs look like now, more than a month into quarantine, and why we could be seeing a second wave of health problems that have little to do with COVID-19. We're talking to Dr. David Carr. Dr. Carr is an emergency room doctor who has nearly 20 years of clinical experience. We spoke back in March about what ERs and frontline healthcare workers were facing as COVID-19 was about to hit Canada. Dr. Carr, thanks for making the time to talk again.
Oh, my pleasure.
So in our last interview, hospitals and frontline doctors like yourself were bracing for the worst, right? We had no idea how high the surge would become, and the focus was really on making sure that there was enough capacity in emergency rooms and ICUs for COVID-19 patients. Now, we know COVID-19 remains very serious, but we're also hearing from Ontario public health officials on the fact that they think we're at the peak right now. So what are hospitals like at the moment? What are you seeing?
Yeah, Adrian, look, I'm a lot more optimistic when we spoke last. I can certainly speak to positivity. I think as we've used mathematical modeling and braced for impact in the worst case scenarios, clearly our physical distancing measures have been excellent in reducing and mitigating the burden of disease. You know, there's a famous quote by storied UCLA Bruins basketball coach John Wooden that says, "Failing to prepare is preparing to fail." And I would say that we prepared very well. What I always hope for is that we would be criticizing for being over-prepared. And if that's the case, fantastic. We have had capacity to deal with the surge in ICU and emerge care. And quite frankly, those surges didn't occur like we predicted they would.
In a lot of ways, this has been one of the better case scenarios that could have happened in the ERs.
Yeah, look, if you look at best case projections that have been put out both provincially and locally, we've exceeded those. You kind of look at, do you want to be Korea? Do you want to be Italy? Do you want to be America? Korea being the best case scenario. We certainly weren't Korea, but we've done well. And I think the key message has to be is it's certainly not over. When you hit the peak, as you mentioned, and I do believe we're at or about the peak, certainly in the community. Now, long-term care is another animal. We can talk about that. But when you hit the peak, if you think about a curve that rises up towards the peak, it means you're halfway there.
By the way, here's Adelstein Brown, the Dean from the School of Public Health at the University of Toronto, on this very point.
It doesn't mean that the disease has left the population. It just means that the current set of interventions are pushing down the rate of infection, which means that we start to see fewer and fewer cases as they go along.
So we have to keep the pedal to the metal and keep going with these maneuvers to make sure the other half is navigated as smoothly as the first half to reach that peak.
What kind of non-COVID-19 patients are coming in right now? What are their illnesses and conditions? Because again, when we spoke earlier, you were saying most of the people that you were seeing in the ER are COVID patients. So of the people who do come in, what are they facing?
This is the big problem. If you look provincially, emergency department volumes are down about 30 to 60%. And this is in light of the fact that most patients aren't able to physically see their primary care providers or advanced practice practitioners or specialists. So one, based on that fact alone, would have expected a surge. But not surprisingly, people just aren't coming to the emergency department. And it has created this secondary wave of emergency providers like myself to be fearful because we're not seeing the patients. And I asked myself, where is everyone? Where are all the people I see with heart attacks, with strokes, with appendicitis, with diarrhea, with trauma? I mean, some things are predictable. Now, granted, people aren't doing sports and probably not operating vehicles as much as they did before. So it would make sense that trauma volumes are down. But there's no sensible explanation that all these other illness and ailments are down. And this really stems from a fear that people have of coming to the emergency department.
I mean, I can understand that sort of sense. The message the public definitely has gotten is that we don't want to overwhelm the system, that if I'm feeling something that might be a minor issue, I'll deal with it. As a person, I don't want to risk exposure and I don't want to get you sick. Are you saying it's time to rethink that?
Yeah, look, I think we need to rebrand the message. Canadian society has done an exceptional job and following instructions and really using the emergency department and using visits and using them appropriately. But to the point of we've kind of gone to extreme, and the collateral damage, and that's the key term here, is what we're seeing is a real delay in presentations. So we're seeing people as simple of having an appendicitis with now ruptured appendicitis who are sick. We're seeing people who have abdominal pain that turns into something more sinister because of the delay. And the big two diseases that I would say I would focus on are heart and stroke. So data came out actually, Adrian, that showed that if they look at activations, an American study that looked at 2 months of activations for what's called code STEMIs, those are like big or massive heart attacks in a whole bunch of academic centers in the United States, they're down 38%. Now, that is not because COVID is entirely protective. It's because I believe that people are ignoring symptoms and not coming in and coming in late. And some diseases like strokes or mini strokes or something like TIAs, the care and the treatments are very time sensitive. So if you have a mini stroke or a stroke, you might have access to a treatment that might be available to you in the first 3 to 4.5 hours after your symptoms. But if you try to minimize your symptoms to say, hey, you know, I really don't want to burden the healthcare system despite the fact that I'm paralyzed and can't talk, that's going to have a really negative effect on you downstream. And that's the collateral damage. And I really want to make sure that people are aware of how safe emergency departments are.
You're saying that doctors, frontline doctors, are missing the warning signs because it's already quite advanced by the time people do come in with something serious.
I'm actually saying patients are missing the warning sign. We're actually seeing very late presentations of illness. So when I see patients, granted, you're right, majority of patients I see when I pick up and look at the triage board, it says fever, cough, rule out COVID, rule out COVID, rule out COVID. But interspersed in that are presentations of sinister pathology that has been delayed. So I'm certainly seeing catastrophic illness. And I think that, you know, most of the stuff I see on a day-to-day basis in emergent, a lot of that can be ambulatory care. I'm now seeing almost entire emergent care, but there's some gray zone in between where patients are waiting too long. So what may have been a treatable illness could be even worse. And it even goes true for people who have COVID, that some of them have waited even really long down the chain, and they're presenting as an extremist in real rough shape. You know, if you look at Boris Johnson, you know, I don't know anything about his medical care, but granted, when he started to feel a bit more short of breath, he went to a hospital. I want to know that people are in touch with public health or people in touch with their doctor. So even if they have COVID, they sort of know when they should go to a hospital. But I want to tell you a little bit about hospitals, if that's okay with you.
Yeah.
People have to realize, and I want to dispel this myth, and I will make this very clear to you. I'm a frontline worker. I see COVID patients. I work in an emergency department. I feel safer working in an emergency department than I do getting groceries. That needs to be very clear to the people who listen to this.
Why?
Because you have to realize that there are professional exposures by doctors and nurses, and there's exposures that people in society have, and they're very different. One, in terms of the seriousness and risk of transmission, but also the encounters that people face. People need to realize that when I come to work, I'm screened at the door. I'm not allowed in if I'm sick. There are no visitors for the most part allowed. If patients come in, they're screened by a screener before they even come to emerge. They're put in appropriate rooms. They're provided with a mask that protects others. And they're put in areas where they're not sitting in a kind of a cesspool of sick patients. They're sitting in isolated areas. The staff who see them are gowned in an appropriate PPE. And you also have to imagine that our housekeepers and workers are working overtime. They've ramped up what they're doing in cleaning, like we're cleaning things out so that it's safe to actually be in the emergency department. You can't avoid coming in for an emergency. Now, look, lots of people didn't need to come into emergency departments before, and that's a whole other discussion we can have when this pandemic settles. But with this pandemic present, people need to realize that it shouldn't be a deterrent to seek emergent care because of COVID. You need to come here. We're a safe place for you to come.
You're saying if you have something serious, the hospital is actually a safe place to be right now.
I completely agree. That's exactly the message. And look, we want people in general in society to use emergency departments for emergencies, but we've gone so far to that other extreme. And let's make sure people don't put things off. Like, I think most patients would say they have chest pain. Hey, they might trivialize it to, you know what, maybe I'm just anxious. The world's upside down and nuts. And I'm sure this crushing chest pain I have will go away. But if your answer to that 3 months ago was, I have crushing chest pain, I need to go to a hospital, then don't use COVID as your excuse not to come.
According to public health officials, we have now avoided the worst case scenario of what could happen in Ontario. If we continue with physical distancing and doing all the things that we're doing right now, do you think that hospitals then have the capacity to treat non-COVID patients right now?
I'm assuming you're meaning elective or planned procedures.
Yes.
Yeah, so I think this is a graded response. I think that one of the barriers that people have to understand why we closed down a lot of planned procedures was a lot of them require PPE. So let's say you need to have an endoscopy or a colonoscopy or a cystoscopy or a bronchoscopy, all these oscopies, which are invasive tests that need to have a patient sedated. These are things that the anesthetist, the surgeon, the nurses would consume PPE. Now, as long as we can ensure that we have a healthy supply and chain of PPE, then we can take the next steps forward in allowing for patients to undergo procedures. The big concern and the big thing that I worry about is what is going to happen to all these patients down the road. Because remember, in Ontario, we have a tight, strapped system to begin with. Imagine that, let's say in the fall or summer, we open up resources to begin testing. Will we have capacity to deal with backlog? Forget PPE. Women who are going to need mammography or biopsy of breast lumps, colonoscopies, all these screening cancer tests that people have not had. As clinics open up, there's going to be a strain on resources again, regardless of PPE. So I have a great worry. Just this other day, I saw a patient and he had been worked up for cancer, but was waiting for treatment and a diagnosis. And he presented to an emergency department out of frustration. And that is not an uncommon thing that myself or my colleagues are seeing, which is late presenters of chronic illness because they may not have received the workup or the care they needed to complete prior to their treatment regimen. And that's a real frightening damage.
You use that term collateral damage. What is the cost of not being able to treat those non-COVID patients in a timely way?
I think it will be huge. It's sad to say, and I don't know, and I'm sure there'll be really smart people who measure this effect downstream. But when we look at COVID mortality and COVID morbidity, what will not be included there is the collateral damage, as you said, the late presentations, And then when we talk about staging of illness, hey, look, if you have a cancer illness and you're at this stage, and if there's a delay, does this move to a different stage? Does that change your treatment and prognosis? That would be a big concern to me. And I'm not sure where we're going. What I do know is that Cancer Care Ontario and other surgical oncologists are working at prioritizing the most important cancer surgeries. And these experts and specialists are looking and working forward to a solution to reintegrating care back into the hospital. And I'm excited for those prospects because they are necessary. And I'm looking forward to opening up healthcare, not just in the emerge, but outside of the emerge.
So David, here in Ontario, at least, the province has talked about how do we restart our society over the next few weeks and the months ahead. Matthew Anderson, the CEO of Ontario Health, he says that they are thinking about this very issue of restarting the healthcare system. What he's also saying, though, is that the province cannot restart it too quickly.
We, in fact, started some expert panels looking at that very question as to when can we bring things back online. And then lastly, and most importantly, is this capacity as we think about how to move forward and as our government considers ways in which to restart our economy and to restart our society, we need to maintain some of this capacity as a buffer should we need to go back into a period or accidentally go back into a period of community spread, and we need a response from our acute care system.
Do you have your own ideas on how do we safely restart the healthcare system?
It's not my area of expertise. I'm seeing this through the lens of a frontline worker. I think that clearly Matthew is right in terms of there will need to be a graded return to normal activity within healthcare. I am certain we will have a second and third wave. Remember, COVID-19 will not end. We will not have completely normal life, in my opinion, until we get a vaccine. And what my big fear, and I think not just mine, but many who, are smarter than me and people who I follow on Twitter and read about in the papers, is when we have our second wave, and let's say it's in the fall, this is going to coincide with flu season, which in our hospitals, seasonal influenza is a tremendous burden on our healthcare resources. Often at those times, our ICUs are at 100% capacity. Our emergency departments are, tremendous over volume. Hallway medicine is a thing. Frankly, hallway medicine has disappeared. There's no beds in hallways anymore. Not an anticipated consequence that any politician hoped for. But I'd like to say that when seasonal influenza comes, we need to have something in place, because how are we going to deal with that wave then? And they're going to be very difficult to distinguish these two entities from one another. And we're going to be a little paralyzed. And I'm certainly fearful for the fall. And I hope this provides an important tool. And I hope public health really stresses that if you thought twice about getting the flu shot, I hope next year or for this upcoming fall, you get the jab the second it's available.
So knowing that by this fall, we, in all likelihood, will not have any kind of vaccine, as a frontline doctor, are you confident about restarting when there is no vaccine yet?
I don't think we'll have any choice. We'll have to restart in a prioritized fashion. I just want to know that we have enough PPE. Similar PPE will be required for influenza-like illness in terms of we won't differentiate, and they're both contagiously spread communicable diseases. So as long as we have PPE and we brace for increased surge and increased capacity, one of the challenges is in flu season, we've had challenges bracing for increased capacity. I think we did a really amazing job in preparing for increased capacity for COVID-19. I hope we can take these lessons politically and economically and advocate that during flu season, there are resources dedicated to increased capacity like we've done for COVID. Hopefully we won't need them. But if we have good PPE and we can open capacity, then maybe we can prepare and open up the gates of healthcare. We can't keep them down so long. We can't.
I just wanted to get to this final point here. The immediate health implications of COVID-19 are obviously pretty stark. Tens of thousands have gotten sick. Nearly 2,000 Canadians have died. But on the front line, what do you think the long-term health impacts of this pandemic will be on the system as a whole?
Look, I think in the front lines, the long-term impact is Patients will slowly adjust their expectations. I hope we can speed it up by education pieces like today. And patients will slowly start to become more comfortable showing up at emergency departments for their care. I hope that family physicians will soon open their offices so that they can have a hands-on approach to patient care and it is not entirely virtual. Expectations will change as this is our new way of life. People, patients, doctors will all be more comfortable with this new reality. We've done it before. When SARS hit, we slowly eased restrictions. We slowly got comfortable in our own skin. We slowly removed some of the precautions. I venture this will happen in a similar fashion, except we were extremely fortunate that with SARS, it never came back. And I think most people would say, this is not going to be that way. This is a global pandemic, not like SARS. So I think we will get there. I think from the front lines, I hope people come see us sooner than later. We're a 24/7, 365 shop. We are always there. Our resources are the same. As for the integration of hospitals, hospital networks, cancer screening, this will be a well thought out collaborative approach that will happen at the right time. Remember, we're at the peak. This is the worst. This is not the time to ease things, but it's the time to fantasize about and prepare for what life will look at sooner than later, and hope that we can have a safe reintegration of medicine as we now know it.
David, thank you again. Really appreciate all your time.
Thanks for having me. Please stay safe. Please make sure people come in. We'll chat soon.
And that is Dr. David Carr. Dr. Carr has nearly 20 years of clinical experience serving in Toronto's emergency rooms. He was there for SARS, and he, along with thousands of frontline doctors and nurses, are there now during this pandemic. That's it for today. Thanks for listening. This Matters is hosted and produced by me, Adrian Cheung, Saba Aitazaz, and Raju Muthar. Produced and mixed by Sean Pattinen, and our director of programming is JP Fozo. Our show theme music is by So Called, and our episode music is by Mike DeAngelis. We want to hear what stories matter to you. Please send us comments, questions, or ideas to thismatters@thestar.ca. Please consider supporting the journalism the Toronto Star Newsroom does at thestar.com. And don't forget to subscribe to This Matters on Apple Podcasts, Spotify, or wherever you listen to your favorite podcasts. Let's talk soon.